principal of Marcus Garvey Technical High School in the parish of St. Anne. We're also streaming live on YouTube, and we welcome to our online listeners. I welcome Dr. Rodine Wallace and Professor Dr. Ian Titus. Each panelist will be given the opportunity to introduce himself. Joining us at a later point in the discussion is Dr. Philbert Emil. He's a counseling psychologist. So Ms. Jones will allow the panelists to introduce themselves, and we're grateful for the use of this platform by Bishop Webster and his team. Thank you, Bishop Webster, for allowing us to use your Zoom platform. Welcome again, and it is our intention, our aim, our objective to have a very informative session on breast cancer. So you leave this platform being more aware, being more educated, and we will have time to answer your question. It will be a short and spicy discussion, and we apologize for the late start. Over to you, Ms. Jones. Thank you. Whilst Ms. Jones put herself together, maybe she's not hearing me. I'm one of your co-hosts, Anne-Marie Bishop. I'm an attorney at law and a mediator. Ms. Jones, are you hearing me clearly? Unmute your mic and introduce yourself, please.
Hello, good evening all. I am hearing you quite clearly.
So we will start with our most senior panelist, Professor Dr. Ian Titus, and followed by, after the introduction of Dr. Titus, we'll ask Dr. Riley to introduce himself, and then Dr. Rodine Wallace, until we're joined by our final panelist, Dr. Philbert Emil. Over to you, Dr. Titus.
Good evening. I'm Ian Titus. I'm a general surgeon, and I see patients who have breast cancer. Very interested in breast cancer, and I'm part of the Jamaica Cancer Society for St. Anne St. Mary.
Thank you, Dr. Titus. We'll now proceed with Dr. Vincent Riley.
Okay, good evening, everyone. Ms. Bishop and Ms. Jones and the rest of the panelists, and as well as the participants who are, join us to make this happen, because without you, we would not have this meeting. So I am Vincent Riley, and what should I say? I'm a cardiologist, and I know a lot of persons are wondering, why is a cardiologist, a doctor who specializes in the heart, here talking about breast cancer awareness? Breast cancer awareness is a very important part of what I do, because I also see the patients from Dr. Titus before they have their surgery, and I see them sometimes after they have had their surgery, which we'll talk a little bit about later on, because when we talk a little bit about the treatment and how it can affect the different organs in the body. But I'm here to add all my support to Dr. Titus, Dr. Wallace, and Mr.
Thank you, Dr. Riley. We'll now proceed with Dr. Wallace.
Greetings, everyone, esteemed panelists and host. It's a pleasure, and our Dr. Titus and the audience at large. It's a pleasure being here. My name is Rodine Wallace. I'm an obstetrician and gynecologist. Of course, an obstetrician and gynecologist have everything to do with not just the vagina, the uterus, but also the breast. And so, this afternoon, it's hoping to be a very good discussion on breast cancer, because we find that breast cancer, despite the multiplicity of awareness that different organizations project out there, we still have our women dying from breast cancer. The latest statistic in Jamaica, 300 women per year. So I'm here to enhance and empower our the panelists as well as the audience, and just to ensure that we don't stop echo the good news or the news to tell our women, not just our women, but our men who are at increased risk for breast cancer to be tested, because early detection can save life. As I said, I'm a gynecologist and I work with the Heart and Soul Cancer Foundation here in Falmouth, Trelawney. I have a passion for helping persons with cancer or to even screen before the cancer will be developed. So I'm here to empower, inspire, and to make this even discussion worthwhile. Thank you.
Thank you, Dr. Wallace. That's so important. The main objective of this evening session is to empower and educate, and prevention is better than cure. And also we want to invite the presence of God in this discussion because we believe in healing as well. By his blood we are healed, right? And by his stripes we are healed. And we'll invite Bishop Michael Webster to lead us off in prayer before we continue the
Pleasant good evening, everyone. It's a pleasure to join you and share with you in this evening's panel discussion. Looking forward to be educated. I'm asked to pray, so let me go right ahead where you are. Just join me in prayer. Eternal Father and our God, we thank you, we praise you, and we glorify you. Indeed, God, the giver of life, and because of that, we bow before you each day with thanksgiving. Each morning, each day that we are allowed to experience, we really give you thanks for that. Your people have come together now to discuss breast cancer and to share information that will be beneficial to especially females, but in particular the family at large. We pray, mighty God, that you will guide them as they talk about this matter. We pray out of this will come some solutions, some helpful tips, some guidance for individuals as they become aware of the need to take it themselves, etc. And so we ask everyone who will share, entire panelists and all those who come will be blessed by this evening's proceedings. In your name we ask and tell you thanks for this and much more. In Jesus' name, amen. God bless you.
Amen. Thank you, Bishop Webster. This question is for any member of the panel. What is breast cancer? We saw where Dr. Wallace showed a short video, but explain, break it down for us and explain to us, or your audience, what is breast cancer really?
So I leave that to this general surgeon, Dr. Titus.
Oh, okay, all right. Well, basically, first you have to basically you have to understand what is, and simply put, a cancer is an uncontrolled growth of cells or tissue within the body. First to the uncontrolled growth within the body, if you want to look at it that way. Uncontrolled means that normally you have tissues in the body which grow, but they are confined within their growth by certain organs or tissues. With the growth continues, and this growth which continues unabated not only has but it also has the ability to enter the bloodstream, or what we call the lymphatics, which are another set of channels within the body, and spread to other parts of the body. By doing this, it can cause destruction of other tissues and can eventually lead to death. So that is in summary, what is breast cancer?
Thank you for that definition, Dr. Titus. Very simplified and to the point, as usual. Is it possible for a woman to detect breast cancer prior to seeking medical advice?
Yes, well, that's the whole aim of it. The whole aim in treating any form of cancer, because of the cycle or because of the growing habit of a cancer, the aim of it is to detect it early. And obviously, the earlier that you detect it, the better it is with respect to treatment and obviously the outcome of the person who has this. So the earlier that you are able to detect it, and traditionally, we have been able to detect breast cancer by the formation of a lump in the breast. It is old school thinking. Now we want, and we are now able to detect breast cancer before it forms a lump by using various diagnostic tests.
Dr. Titus, can you elaborate a bit more on the tests that is done
Okay, well,
to detect
basically,
breast cancer?
as you know, there are a number of tests that I use to evaluate the breast, both in male and female, more so in female than in male. The mammogram is the one which has gained most popularity. Basically, what a mammogram is simply put an X-ray of the breast. And by looking at the images that are taken, the radiologist can identify areas which are suspicious and which will need further evaluation. These areas can be identified even prior to them developing a lump or something that you can feel, right? The mammogram is the one that has been most popular, but the ultrasound has also been used. And more recently, so-called MRI or magnetic resonance imaging has also been used to evaluate the breast with respect to diagnosing and treating breast cancer.
Thank you, Dr. Titus. Dr. Wallace,
Yes, I am.
could you, I would not say demonstrate for us the self-examination, but could you walk us through the steps that women need to take on a monthly basis to carry out the self-examination, and why is that important?
All right. So typically, on a daily basis, weekly basis, or as you said, monthly basis, a woman, once you're intimately interacting with yourself, you understand what your body looks like, and in particular, your breasts. From inspection, the basic inspection, you stand in front of the mirror, or if you don't necessarily want to interact with the mirror, but you want to interact with, I suppose, and well, a lively object, then you can have your significant other assist you with examining your breast. But we start with inspection. So a woman can look to see, or if she has her partner, can look to see if there's any change in the size or the shape or the contour of the breast. So you look for anything that look abnormal just by looking in the mirror or having someone assessing you with the examination, looking for lump, puckering, even the color of the breast looking like they call it poor, or well, I mean, sometimes I can't pronounce it, the orange skin looking area at the nipple.
Port orange.
So yes, Professor, thank you very much. Port orange. Now, after inspection, then typically you move on to palpation. And so it's just a scientific, well, not scientific, but a more organized way to, it said that, you know, you can, for the left breast, use the right hand above your head to basically extend the breast in a more proper symmetry. And then you try to evaluate the different quadrants. So you can divide the breast into 5 quadrants. You have 2 outer, 2 inner, and the center. You try to palpate each quadrant, feeling, pressing against the chest wall, pressing, feeling for any lump, any abnormal feeling inside the breast. And after you would have finished each quadrant, you move on to, you can express the nipple to see if there's any blood or any abnormal discharge. Then you do that to the alternative breast. Also, you want to, even before the end of the examination, examine under the armpit to check for lymph nodes, because sometimes you can have breast cancer that manifests itself as a lymph node. So in essence, an individual, a woman being intimate or interacting with herself, more so in the mornings, taking a shower once per week, you examine by inspecting the breast, examine the breast from the different quadrants, express to see if there's any abnormal discharge, and you feel the armpit or any lymph node. So that's a basic initial assessment from a personal perspective.
Thank you, Dr. Wallace. And it's very important for us as women to do that self-examination on a regular basis, correct?
Yes, ma'am. Very, very correct. And
Thank you so
importantly
much.
too, Miss Bishop, if you feel something abnormal, don't just keep it to yourself. I mean, you can share it with your family doctor, your family member. Just share it with somebody who might be more knowledgeable to say, hey, this is not something that you sit around, you wait and watch and see what is going to happen. Because you wait and watch and see might be so advanced when you really need to take action. So if you see something that is not in keeping in what your normal breast used to be, then it's best to act.
Thank you for that information. I see a Mr. G with his hand raised. I'll acknowledge him. Open your mic, please, and ask your question or make your comment. Thank you.
Hello, good night.
Good night, sir.
Good
Two
night.
questions.
Good night, Mr. General.
Two questions. Recently I watched a clip where a doctor was saying that when the breast is being sucked by the baby or men, it can help to prevent breast cancer. How true is that?
Professor Titus.
I see Dr. Riley smiling.
Could you repeat the question? I didn't hear it, but you can answer, Vincent. I
can answer Vincent. Okay. Well, see, he's asking the cardiologist to answer you, Mr. G. So, I mean, I can understand. I don't know if there is much credence, but I know during suckling of an infant, there are certain hormones that are produced, which can, help with breast health, also helps with the uterus. I'm not sure much about breast cancer if your partner suckles on your breast, because that sort of produce other sort of hormones for procreation rather than for prevention of breast cancer. But I know there may be some credence or some truth or some hypotheses or thing with regards to when the baby suckle. So I don't know what Dr. Titus' thoughts are about, because it's two separate events. One is your partner, and that could be at any age. I mean, 65-year-old, 80-year-old, or 18, or the suckling of the breast, which is within the childbearing age, where different hormones are produced. Dr. Titus, what are your thoughts?
It's not the suckling of the breast, whether by adult or child, which has anything to do with anything. It's the hormonal status of the patient. And what we do know is that women who have prolonged uninterrupted exposure to estrogen tends to have a higher incidence of breast cancer. Now, what do I mean by prolonged uninterrupted exposure to estrogen? Women who start their periods early in life and go for a long period before having children. So they start their periods early in life, so they have early onset of this estrogen surge. And this estrogen surge, it is not interrupted by having children. So early onset of having your periods and late onset of having children is associated with an increased incidence of breast cancer because by virtue of the fact that there is a prolonged exposure of uninterrupted exposure of the breast to the estrogen.
Thank you, Dr. Titus. I hope your response, the response of yourself and Dr. Riley was helpful to Mr. G. How do we treat breast cancer?
Well, as I was telling some people today, in any form of cancer, the treatment depends on the stage. And generally put, the stage of a cancer is a reflection of the extent or advancement of it. In other words, when it is detected early, that's an early stage. When it is detected late, it's a late stage. And clearly, the earlier it is treated, the earlier it is detected, the more efficient the treatment can be. And the treatment will vary according to the stage. Now, this is where it gets a little bit complicated. Because over the years, the treatment of breast cancer has undergone a number of changes because of the constant research that is being done into the results from treatment of breast cancer. To put it generally, there are 3 or 4 modalities of treatment for breast cancer, 3 or 4 ways that it is treated. We all know about surgery, and surgery in itself, there are different forms of surgery that are used to treat breast cancer. That's one. We'll discuss it further. 2, there is chemotherapy. And chemotherapy is a form of treatment where the patient is given medication in an effort to slow or retard the growth of cancer. And more these days, chemotherapy is playing a more important role in the treatment of breast cancer. We'll go into that as well. Then there's radiation. And this is the use of variations of X-rays to treat breast cancer. And that too has its role to play. And then there is immunotherapy and other forms of generalized therapy, which are used to treat patients in general with cancer. In other words, we know that the person who has a cancer does better if they have and adopt a holistic approach to their treatment. In other words, a person who is healthy and who has a general good attitude towards their treatment tends to do better than the person who does not have these things in their favor. And this is where other people and other forms of treatment, like the psychologists, the psychiatrists, counselors, and so on, come into play in assisting in the general treatment of breast cancer. So that's a general overview, and then I think we can take each one step by step as we go along.
And we will, Dr. Titus. Thanks for the information. But what I hear you saying is the treatment of breast cancer from a person is diagnosed, and the entire treatment, it's a holistic approach to include the nutritionist and the psychologist, correct?
Absolutely, yes.
Very well. I see raised hand by Kalisha Kerr. Can you unmute your mic and ask your question or make your comment, please?
Pleasant good night, everyone.
Good night.
It's an interesting topic, but my question to it is, what are the main cause other than just maybe finding a lump or so? What are stuff that cause or can cause cancer to occur on a normal base without a genetic gene from a family member having it or a part of your family? That's my question.
From what I'm gathering, doctors, Ms. Carr is suggesting that breast cancer is also genetic. Is that so?
Yeah. So thank you very much, Ms. Carr. That's a very good question. I think the interesting part about the bits and pieces of that question is that it's not really what are some of the risk factors for breast cancer in particular, apart from genetics? Because genetics is one of the big ones that we focus and we talk a lot about, because over the years we have been able to identify some genes. I'm going to talk a little bit about genetics quickly, associated with breast cancer as well as other cancer like ovarian cancer. And we see sometime in our celebrities who had these genes and they had their breasts removed in an effort to prevent themselves from getting breast cancer. And so there are about 4 or 5 genes that persons talk about. And genes tend to be in family. So if you have a family member, first degree, we hear about first degree as your mother, your sister, or an aunt who has breast cancer or some form of cancer, then you're at increased risk. So the risk factors for breast cancers really are: 1, if you're a female, it's higher in female than men. If you're getting a little bit older in terms of increasing age, there are other risk factors that was mentioned by persons as they talk. Radiation is a risk factor. Exposure to radiation, what we call ionizing radiation, can cause put you at risk for breast cancer. Dr. Titus mentioned about prolonged exposure to estrogen, hormones. So hormonal thing. There are also some environmental factors like cigarette smoking and things like that, which has put us at risk. And then, of course, obesity. We don't really think about it, but obesity, some of our lifestyle diseases, not necessarily diseases, but challenges, obesity being one, put us at increased risk for breast cancer. But one of the main drivers for breast cancer is genetics, including the family history of first-degree relatives who have breast cancer and persons who have the genes. There are other risk factors, I guess, inflammation, chronic inflammation, or some conditions that might be going on that will put you at risk of breast cancer. I don't know if Dr. Titus and Dr. Wallace wants to, start to add a little bit more to some of these risk factors.
I think that has summarized it very well.
Thank you, Dr. Titus.
Complete.
I realize that Mr. G has his hand up. I don't know if it's from previous or it's a fresh hand, fresh virtual hand, Mr. G.
Yes, it's a fresh hand.
Okay. Go ahead, please.
Question. Is there a greater risk based on the size of the breast?
Certainly, the larger the breast, the greater the risk?
Simply put, no.
Mr. G, I must say we have done this program multiple times, but it's the first I'm hearing that question. But thank you for
Okay.
your question.
That's an interesting concept because there are a lot of breast enhancing surgeries that are being done worldwide. Persons want more. So I guess probably because the risk of cancer with all these enhancements is not that great. But some of the things that they're using to enhance the breast, I'm sure Dr. Titus will add that some of these can increase your risk of getting breast cancer. Dr. T?
Actually, there are some people who also want less. It's not everybody who wants more, right? There are some people who actually want less. So you have breast reduction surgery as well. That goes on. No, the size of the breast has nothing to do with the development of breast cancer. It has certain implications in terms of treatment. In other words, certain size cancer in a small breast might have a different implication from that same size lump in a big breast. But the size of the breast has nothing to do with the genesis or formation of breast cancer. No.
Thank you, Dr. T. Dr. T, earlier you mentioned the 3 or 4 ways, modalities of treatment. Can you just give us some more information on each, please? Surgery, chemotherapy, radiation. Those are the ones I noted.
Surgery has for many, many years been sort of the gold standard of treatment. And even that has come under significant review over the last couple of years with the advent of breast conservation surgery. In other words, with the advances with early detection, where we are detecting cancers at smaller sizes, then the tradition of having a breast cancer and having a mastectomy, which is a removal of the breast, is now, the role of it is different in that breast conservation, where we are able to do surgery for the cancer, but still preserve the form and nature of the breast, has come into its own. And this is, again, one of the advantages of early detection. Clearly, one of the things I need to see at first, at the outset of treatment, is that for every patient, for every person, the treatment needs to be individualized. So there is not one brush that paints all. So once you are diagnosed with breast cancer by whatever means, and we haven't really got into the methods of diagnosis, but once you have been diagnosed, then the treatment is an individual situation between a team of persons, the patient, the surgeon, the oncologist, radiation oncologist, your nutritionist, and so on. So we're talking, as I was saying about surgery, the role has changed in that we're moving more and more to breast conservation, where rather than removing the whole breast, you may remove a part or a segment of the breast and treat and add additional treatment. Chemotherapy. Chemotherapy has become much more involved now in the treatment of breast cancer. Traditionally, we used to have what is called adjuvant chemotherapy, where chemotherapy is given after surgery. Much more now, these days, we have what is called neoadjuvant chemotherapy, where chemotherapy is given before surgery and is becoming more and more the first line of attack in the treatment of patients with breast cancer. Why is this so? Because, as I was saying earlier on, the studies and investigations are now supporting that in a significant number of patients, if they receive chemotherapy before surgery, then their outcomes in terms of length of survival and disease-free survival are much better, much better. And look into the future. I personally look forward to the day when breast cancer will be treated completely with chemotherapy and surgery won't have a role to play at all. But we have not yet gotten to that adjunct. Radiation is also an adjunct or an addition to the treatment. So basically, it is an individualized process depending on what your diagnosis is, what type of cancer you have, your age, your genetic status, and so on. All these factors are taken into consideration in determining what is the best method of treatment for you.
Thank you so much, Dr. Titus. We have 2 questions that were posted in the chat. The first question, are there any food that should be avoided for persons who would have been diagnosed?
A difficult question to answer. Well, let me ask Dr. Wallace to answer that.
I probably need to call a friend. Well, I mean,
I tried to get a nutritionist, but nobody was available for today. So my apologies, but let's see how best we can navigate the question. Thank you.
Wow. As it relates to the, risk factors from a food perspective, I am thinking about it, and I see where, it wouldn't be food, but medication as it relates to hormonally driven medication, estrogen based. There's a thought out there that speaks to chickens, these food that have been injected with certain hormones. Could they be a risk factor for, cancer? Also, as it relates to, the whole treatment aspect of breast cancer, you definitely want, from a nutritionist perspective now, healthy food to eat so that your immune system becomes robust. So you want a balanced diet, your fruit, your vegetable, things that have probiotics and good taste to strengthen your immune system. But as it relates to food directly associated with increased risk factors for breast cancer, I am yet to, see research that directly link such association. This is the seminar you call a friend, so I can call on my good cardiologist.
Yeah. All right. So thank you, Dr. Wallace. So really, it's not directly food. It's really having the healthy diet. And as he alluded to, it's your fruits and vegetables, your greens, which is what is for what we call non-chronic, non-communicable disease prevention, diabetes, hypertension. It's a similar diet, and avoiding fried foods, which increase cholesterol and cause obesity, or processed food, processed meats. For example, I don't want to knock any producers, hot dogs, bacon, which he alluded to. Some of these foods have higher cholesterol content or free fatty acids, as well as bad oils in them. So you want to avoid those foods, especially processed foods, and stick more to your fruits and vegetables, your greens, and watch your portion side as well, because those are very important. It's things to keep you healthy, really. It's not necessarily specific for breast cancer. Although persons, you go to Dr. Google and he will talk about food that are laden with carcinogens and things. which we'll hear of. But it's more, I'm not sure a lot of it is in breast cancer, but like, for example, some persons with bladder cancer, we talk about certain type of food. And of course, as he mentioned, probiotics, and there are other things that can be done. And exercise. Exercise and controlling your weight is very important as well, especially in keeping us healthy to fight, especially preparing us for the treatment if you are diagnosed with breast cancer, because it may involve surgical treatment, involve chemotherapy, involve radiation, and involve hormonal therapy or immune therapy, as Dr. Titus, and chemotherapy, which Dr. Titus mentioned.
Thank you, Dr. Riley and Dr. Wallace. And I'm glad you mentioned the importance of exercise, Dr. Riley, because whether or not you are diagnosed with breast cancer or any cancer, it's important for us to try to engage in a healthy lifestyle. Prevention is better than cure. I now recognize the hand of Mr. J. Legisto. Mr. Legisto or Miss Legisto, please proceed.
Good night. I don't know if it was asked before I came on, but I want to know what they mean when they say aggressive cancer, what that means.
It's very simple, ma'am. It means that it spreads rapidly and behaves aggressively. Now, the term is a subjective term. In other words, it will mean different things to different people. So you have to be careful when somebody says a cancer is aggressive to identify specifically exactly what they mean. And it is a term that I would not use in a general discussion. I would use it specifically for an individual person with respect to their specific disease, where I would say it is aggressive or not aggressive, depending on the characteristics of an individual. But I would not say, for example, breast cancer is an aggressive disease. I would not say that, because it's not a term that I would use in a general concept to describe any form of cancer. It depends on its behavior.
Okay, thank you.
Thank you so much, Dr. Titus. Another question coming from the chat. Can tight bra or wearing smaller bra than your breast size cause cancer? Dr. Riley, I see you shaking your head. Basically, the person is asking whether the bra that they wear affects.
We have two persons here, one who knows about tight bras and loose bra, Dr. Wallace, and Dr. Titus as well. So I want to defer to these guys' expertise.
Well, there's no association between a tight bra or a loose bra with breast cancer. I mean, the reality is that for support system, now if you have been diagnosed with breast cancer, of course, nobody's gonna expect you to wear tight bra, which can make the process uncomfortable. So there's no association. Dr. Titus can back me up, but I know there's none.
Simply no.
Thank you, gentlemen. Somebody in the chat, Zoom user, and this question concerns me. A 27-year-old mother with a 1-year-old child recently discovered a lump in her breast and her nipple is sticking to her bra. And they're asking the opinion of the panelists.
It's very difficult to give an opinion without seeing the person. What I would suggest that that person does is go and see a physician. Very, very simple. It could be a number of things. You say she's 1 year, she has a 1-year-old child. It depends on whether she's breastfeeding or not. It could be related to that. So it's very, very difficult to give an opinion like that. But I would suggest if she's concerned, she goes and sees a physician.
Thank you, Dr. Titus. The other question from the chat is, what if you have on and off pain in the breast? Should I be alarmed?
Dr. Wallace?
Well, I mean, the reality is that if you're accustomed to not having pain in your breast, and a normal individual breast should not be paining them. So if you're now becoming having discomfort from pain in your breast, most times pain is associated with the advanced stage in cancer, not necessarily the early stage of cancer, if it's going to be cancer. But if it's discomfort, I recommend you get it checked out. Of course, there are many causes for pain in the breast, which you could list them out. But if you're uncomfortable to the point that you're so concerned, it's best to check it out, see a physician, and then they'll take it from that angle. They'll have to take a history, see what happened, if the breast got hit, if something went on, aggressive suckling and some other stuff. So from that angle, yes.
Thank you, Dr. Wallace. Recognizing the hand of Zoom user, go ahead, please, with your question. Zoom user, please unmute your mic and ask your question. Okay, we'll proceed. Dr. Riley, does breast cancer, you're a cardiologist, very experienced, very knowledgeable.
Mhm.
Tell us about the role of a cardiologist, if any, with somebody who has been diagnosed with breast cancer. What role would
Okay, so as I had mentioned earlier in my introduction, that the role of the cardiologist tends to be one, because if you think of breast cancer, it tends to be the majority of the patients with breast cancer will not be seen by a cardiologist because some of them tend to be young. It's the older age group. The older age group persons are the persons who have what we call chronic non-communicable disease, diabetes, hypertension, high cholesterol. And these persons, invariably, some of them would have had a heart attack or they would have had a stroke. And now these persons requires major surgery. Some of these persons have heart failure. They require major surgery. So an invitation will be extended to myself or one of the cardiologists in assessing these persons before surgery as to how this person will do during surgery and after surgery, seeing that they have some comorbid illness before. All right. And that is really my role initially before when the patients are diagnosed with breast cancer. However, one of the complications of one type of chemotherapeutic agent, which is used in patients with breast cancer, can affect the heart itself. And it affects the heart in such a way that the function of the heart, the squeezing of the heart is reduced, and these persons tend to have shortness of breath, heart failure. You can imagine someone with advanced breast cancer now having shortness of breath, and you're not sure if the cancer may have spread to the lungs, if the cancer has now caused a lot of fluid in the lungs, or whether or not this patient's heart has been affected by the chemotherapeutic agent. And there's really just one in particular. And that is the time they will invite the cardiologist as well to assess these patients to decide whether or not to discontinue that particular chemotherapeutic agent, or they can continue, especially if the patient is having a response to that agent, and assessing and monitoring the progress of this patient. So that is where the cardiologist tend to come in, and from time to time, we're asked to do ECGs and evaluate to see if there is any change in their ECGs. Because we have to bear in mind, although we're talking about breast cancer doesn't stand by itself. It's something that affects an individual, and that individual is affected by a lot of other challenges as well. So from time to time, you will need different specialists to see these patients, not because they have breast cancer, but because they have other comorbid illness.
Thank you so much, Dr. Riley. Ms. Carr asked a question in the chat. She says that she normally feels pain in our breast after cleaning, washing, would the advice be the same as given earlier?
We did not hear you there, Miss Bishop.
Miss Carr? Sorry about that. Miss Carr?
Right. Because I may switch my hat. It depends on if you're having pain from cleaning, washing, and sweeping, and depending on your age and your comorbid illness. If it's on the left breast, it's me you need to see, and not the surgeon. You need to see a cardiologist. So we have to be careful with regards to pain. If it is on one side, the left side in particular, and it occurs with activity, and dependent on your age and your risk factors, then you may need to see your primary care physician, who will decide whether or not to send you to the cardiologist or send you off to have investigations for the breast. Ms. Carr is online.
Good
Go ahead,
evening.
Miss Carr.
My mother, she's 60 years of age, but whenever she works hard, like laundry, anything of that, she complained that she's having like a burning from the armpit down to the underneath the breast, right over to the breast, but it's mainly from the arm in, and she keep complaining, but it's only like if she do hard work. For instance, she does laundry and wash and hang out and all of that and work after. That's when she complains, and she said it's been going on now for about a month.
Okay.
So
is it to any particular side? Is it to the left side or the right side?
I'm not sure, but I know it's from either the right or the left, but it's from the armpit into the breast.
It's important to find out which side it is, because if it's the left side, then it might be related to a cardiac problem, something like angina, for argument, just for throwing it out there. Because if it's to one side and she's 65 years old, then her risk of having, I know we're not discussing that, what we call atherosclerosis with coronary artery disease is high. So it may not have anything to do with her breast.
All right, thanks much.
Yes, I think anybody who has pain or shortness of breath on exertion or physical activity, especially if it is chest related, should in fact have their heart and blood pressure and so on evaluated.
That's true.
Thank you, Dr. Riley and Dr. Titus. Bishop Webster, do you have any questions for our panelists? Bishop Webster? All right, we're not hearing from him. Just to remind our online persons who have joined us and those who are joining us on YouTube, we have Professor Dr. Ian Titus, who is a surgeon and a specialist when it comes to cancer.
I don't know why you keep calling me professor.
Okay, Dr. Titus. We have Dr. Vincent Riley, who is our cardiologist, very experienced. We have Dr. Rodine Wallace, our gynecologist, everything female, everything woman. He's the person to go to. And this evening session is a partnership between the Bishop Law Foundation and the Heart Place and Wellness Center. I'd like to use this opportunity to say thank you to Bishop Michael Webster for allowing us to use his platform. And I recognize a number of Kiwanians who have joined us, Rotarians, persons in the school system, as we continue our discussion on breast cancer. Dr. Titus, you mentioned a number of modalities in terms of treatment. Which of the four that you discussed earlier is the most effective, or does it depend on the stage of the cancer and the individual age?
A difficult question, yes. As I said,
My apologies.
No, that's fine. The treatment, again, of any cancer is going to be individualized. What I think we need to realize more these days is that more patients are having more than one type of treatment these days than before. You know, it's gone are the days when it was just surgery, some form of surgery that is used for treatment, right? Now, more the other modalities are being brought into place and have increasing relevance in the treatment. So it is not that one is more effective than the other. It is that all the modalities complement each other, and it will depend on the wishes of the patient. It will depend on the stage of the disease. It will depend on the type of breast cancer you have to determine which of these methods and how many of these methods we use for treatment.
I have a question for Dr. Wallace. All right. So, Dr. Wallace, because a lot of you know, we talk about hormone and the breast and relationship with breast cancer. Can you talk to me a little bit about contraceptives, how hormonal contraceptives like the Pearl and thing that persons use? Is it related to increased risk of breast cancer? And then, of course, as Dr. Titus may have mentioned, prolonged exposure to estrogen and hormone replacement therapy in our menopausal ladies.
All right. Thank you very much for that question, Dr. Riley. And just piggying back to what Dr. Titus would have mentioned earlier on with regards to estrogen and being exposed for a prolonged period of time. We know that our birth controls, they're made with estrogen, some with progesterone and estrogen and other ingredients. So we know that one of the things that happens is that they taper the dose of estrogen in some of these birth controls. So while the concentration may not be sufficient to, have great exposure to breast cancer, we still advise our patient who have high risk of breast cancer to avoid some of these birth control, that especially with increased concentration of estrogen. Now, as it relates to the hormone replacement therapy, again, hormone replacement therapy tends to be given in the gynae patient who may have reached menopause and still having certain symptoms from menopause, and we want to enhance their life processes. So hormonal replacement therapy can be recommended, but one of the things to appreciate is that there's some breast cancer that is estrogen hungry and it's estrogen generated. So it is always cautioned and advised not to prescribe hormone replacement therapy, especially estrogen, in these patients who have breast cancer or breast tissues with estrogen receptors that can enhance or make estrogen related breast cancer more aggressive. So from those two respects, you can make an association with hormonal contraceptive or hormone replacement therapy with breast cancer. I hope I did justice.
Thank you, Dr. Wallace. Continue, Dr. Riley.
No, I didn't have any more questions. I just wanted to get that clarified.
Okay, thank you so much. Ms. Jones, do you have any question for our panelists?
There are two areas that I would like to touch on.
Please proceed, Dr. Titus.
One is how the diagnosis is actually made, which we haven't really spoken about, and that is a procedure called a biopsy. Again, this is a procedure that is done usually after some investigation, whether it be a mammogram or ultrasound or an MRI or even a clinical examination, has detected that there is a lump in the breast that is suspicious. More and more these days, we are moving to what is called core needle biopsy. What this means is that rather than having an operation as such, where you get a cut in the breast and the lump is removed, a small needle is used under local anesthetic. In other words, you are given a little injection to deaden the area, and a needle is used to take out pieces of the lump, and these pieces are sent to be tested. As I said, this is usually done in situations where the investigations, whether they be ultrasound, mammogram, MRI, or the examination suggests that this lump might be a cancer or this area might be a cancer. There are some people, some surgeons who do it for all lumps. But I think in our local situation, lumps which are not cancerous, the patients are going to want the lumps removed. But let's leave that for the time being. So more and more we move towards this core needle biopsy, which is a much more comfortable procedure than the operations that we used to do. But it also has another advantage in that, and it has taken some convincing to get some of our women to understand why we need to do it this way. Because most women in our local situation, when they have a lump in their breast and they say, oh, there's a possibility of it being again, I said, I wanted to take it out, doctor. I want to take it out. That tends to be one of the first reactions. But especially where the lump is large, when I say large, I'm talking about above the size of an inch. The needle biopsy is important because a lot of those patients are going to be candidates for chemotherapy as the first line of treatment. Now, when this is done in the setting where the lump is still present, it affords the advantage of observing the response to chemotherapy. And that's very important. Where given the chemotherapy before, and you can see that the lump shrinks and gets small. In some people, it actually almost disappears. Then you know that this person will respond to chemotherapy, as opposed to the patient who has had the lump removed, it's a cancer, and then you give them chemotherapy. You have nothing to judge your results by. Mm-hmm. So that's one of the advantages of using the core needle biopsy. And as I said, this is becoming more and more popular these days. That was one thing I wanted to talk about. The other thing I wanted to talk about was receptors in breast cancer. Once the diagnosis is made, and the diagnosis is made, I said, when bits have been taken out and sent to the lab, and the pathologist looks at it under the microscope and they say, yes, this is breast cancer. But the diagnosis doesn't stop there. There are further tests which are done on that sample which is taken out. And the most important ones are what we call receptors. The important ones being the estrogen receptor, the progesterone receptor, and one called HER2. And these three receptors determine or help to determine the type of treatment that the patient gets. What I mean, patients with estrogen and progesterone receptors that are positive when you test it, they tend to be put on anti-estrogen drugs. The popular one is a drug called tamoxifen. All right. Patients who are HER2 positive are given a drug called Herceptin. Patients who are what we call triple negative, in which the estrogen receptor is negative, the progesterone receptor is negative, and the HER2 receptor is negative. Those patients are channeled into the chemotherapy path because it is thought that these patients may have a worse prognosis. They may tend to do worse if their treatment with chemotherapy is not started early. So those are two aspects I wanted to speak about, because anybody who's diagnosed will hear their physician talk about core needle biopsy and its use in diagnosing the breast cancer, and the role of receptors in determining the type of treatment that you get.
Thank you so much, Dr. Titus. Dr. Titus and Dr. Riley and Dr. Wallace. The 4 modalities of treatment were mentioned. What are the risk factors, if any? And we are aware that no treatment is perfect, but Dr. Titus did indicate that it's an individualized treatment, it's not general. It depends on a number of factors. So the treatment that is given to the client is determined by whether their age, the stage of the cancer, and so on and so forth. What are the risk factors associated with the treatments that were outlined earlier in this discussion for the treatment of breast cancer?
Okay, so you're speaking with regards to the complications of the different modality of treatment. I'm going to leave that to the person who does the treatment, Dr. Titus.
Say that again, Vincent.
I'm going to leave a lot of the treatment, the surgical treatment, and you would have seen most of them.
I with you, Dr. Riley. Dr. Titus, Professor Titus.
Yes. These side effects you're talking about.
Yes.
Yes, Dr. Titus.
All right, well, the side effects of surgery are the side effects of any other major surgery. Right? Depending on the type of surgery and the extent of surgery that is done. Clearly, the side effects from a mastectomy when you remove the whole breast will be different and can be more extensive than when you have what we call wide local excision or segmental mastectomy where just a part is removed. The one I know that most people, especially these days, are very concerned about is chemotherapy. And more women tend to be wary, let me use the word wary of the side effects of chemotherapy. And chemotherapy does have its side effects. The thing with chemotherapy for breast cancer, it is a mode of treatment which is in evolution. In other words, the drugs they were using 5 years ago are different from the drugs they're using now. And they are getting better. The common side effects, which most people know about, is nausea and vomiting, which can occur at the onset of treatment, but tends to get better over a period of time. Hair loss, which again usually extends for the period of time that they are on the treatment, but when you stop the treatment, the hair tends to grow back. Some people have a generalized weak feeling, and this is where nutrition and so on is very important. They tend to get a weak feeling because of the chemotherapy. Some people get discoloration of the hands and feet, which again tends to be temporary. And there are other side effects. One significant one is the one Dr. Riley spoke about, which can affect your heart. Right? One of the drugs which our local population has nicknamed the Red Devil. Doxorubicin is one of the drugs which gives a lot of the side effects. And the ladies who go for chemotherapy come back and tell you, boy, doctor, give me the Red Devil, because it tends to have a lot of side effects. And it's red, that's why. But the side effects tend to be temporary and transient in most people. I've had patients who have had it very, very severe, especially nausea and vomiting, which has been resistant to the standard forms of treatment and has required other forms of treatment grown in some of our local backyards. But the side effects, as I said, tend to be transient and varies from person to person. Radiation has come a long way in that the effects of radiation tend to be local. In other words, at the site where the radiation is given, the patients may feel, not at the time, but over a period of weeks, a tingling or mild burning sensation, again, which is transient and which tends to go away, and which is less now with the type of radiotherapy machines that we have in Jamaica, which is better than used to be before. So the side effects will vary depending on the medication you take, and what I would encourage people to do is that have a discussion with your doctor as to, all right, doctor, what you're going to give me and what are the side effects, and then you can go into it.
Thank you, Dr. Titus. Ms. Stephanie noted in the chat that one of the side effects is changes in the color of the nail bed, and sometimes your nails fall out.
Yes, I said that. Then you get a discoloration of the fingers and feet, your nail beds and your fingers. They get a little darker, and it's because of one of the drugs that's used.
Thank you so much. We have Dr. Filbert Emil on, but before I get to you, Dr. Emil, Dr. Emil will take us through the perspective of a counseling psychologist and the effect that a person with breast cancer, the effect on the family and on the individual, the emotional state of mind, their mental wealth and health. But we will recognize Zoom user who wants to share her experience.
Hi, good night, everyone. Are you hearing me?
Yes, we are.
Yes, we're hearing you clearly. Thanks for continuing to try.
Yes, had to go in settings. So I am now the 28-year-old female who was the 27-year-old female when I noticed I had a small, at that time it was 2 centimeters lump in my right breast. The lump came first, and this was shortly after breastfeeding my son. I breastfed him for 6 months. After the lump, I noticed sharp pain, then which my right nipple would stick to my bra. I went to my dermatologist first with the issue because to me it was a skin. I wasn't really paying much attention to the lump. I was really mostly paying attention to my nipple peeling off in my bra. So I went to my dermatologist. He at first thought it was Paget's disease, possibly, but as the doctor said, you have to do a biopsy to conclude. He then referred me to a doctor that referred for me to do a breast ultrasound. Because of my age, they said that they did a breast ultrasound instead of a mammogram. On the breast ultrasound, when the results came back, it was stated that the lump is 2 centimeters and it does not seem to be malignant of nature. They couldn't answer, or they did not answer as to why I was feeling pain or why the nipple was peeling. They just suggested that I do a follow-up 6 months later. 6 months later, the size of the lump had grown to it was like half of my breast. So half of my right breast is now hard. And the pain was always on and off. It was mostly, to me, from my observation, it was mostly around the time of my menstruation cycle. I would feel, or if the time is cold, I feel the sensation of the pain more. I did see a doctor, but at this time I was not in Jamaica, because I'm not in Jamaica right now. And I went to a doctor, and they were alarmed, and they did, because I know half my breast is hard. And they did a biopsy, which showed that I have a grade 3 breast cancer, which means that it's very aggressive. And it also spread to my right lymph node under my arm. So I recently started chemo. I did only one therapy so far of chemo. So I'm going through the motions of it. But I was what baffles me the most is the fact that I went to my doctors from this lump was 2 centimeters from, it was small. I am very talkative, so I'm always telling my guy, like, I have this lump here. I went to the doctor, and it was like, it was just overlooked that possibly this 27-year-old, even though she's young, and I don't really have a history of breast cancer in my family. Know that I am diagnosed, I found out that I have a aunt from my father half sister that has it, but that's how distant she is. So I don't really, it's not in my blood. I did the BRCA test recently. The results are not back in, but it was just baffling to me to know that I tried my best. I'm always the one that goes to the doctor for everything, and then to find out that I had this thing from, it was 2 centimeters, and now it's 9 centimeters, half of my right breast, and nobody caught it back home. So I wanted to share that experience.
Thank you so much for sharing, Zoom user.
A comment I would make on that. Yes, I think you should have had a biopsy before. I think you should have, even when the fact that you had weeping of the nipple with the lump, I think you should have had a biopsy. The other thing is, though, you said you have grade 3. You must mix up the grade with the stage. It's not the same thing.
No, they didn't. They said grade. They said grade 3 because
it's not the same thing.
Right.
I think based on what you tell me, you probably have stage 2.
Right. They didn't tell me that it was stage 3. They said grade 3.
Right. The grading is when they look at it under the microscope, it's Nottingham. That's the name they attached to it. And you have different grades. And it is a rough, very rough estimate of the aggressiveness of it. You might be surprised based on your chemotherapy, the response you get. Believe me. You might be surprised that you might get a very good response. You sound like a person who doesn't give up hope very easily. I can tell that by your voice. And I know I feel you're going to do well. If you are optimistic, and you obviously will stick with because what you're getting is what is called neoadjuvant chemotherapy, which is chemotherapy before. And they need to look at the response that you get over the next couple of months, and you might be surprised.
Yes, thank you so much. Yes, I am. I have to stay strong. I can't give up.
Zoom user, sorry for your, it's a challenge when you're young to be diagnosed with any form of cancer, and really breast cancer at 27 is quite difficult. because I have seen some patients. I mean, as I said, I'm cardiology, and I see some of the young ladies who have had aggressive chemotherapy at age 32, who now have, you know, I'm now managing for heart problems related to chemotherapy. The one that the Red Devils, Dr. Titus, speak about, you know. But you know, it's at 27 with a lump in the breast and weeping. You know, I listen and I empathize. I can understand your physician treating you for Paget's disease. Because Paget's disease, you know, is that Paget's and Bowen's, Dr. Titus? Bowen is the other one.
That's correct. That's correct.
Yeah, wherein these are skin conditions affecting the nipple that are associated with breast cancer. Because a lot of times we, you know, the ultrasound, I am not sure, I don't know, Dr. Titus can probably correct me and guide me when an ultrasound say that it doesn't look like a malignancy. That's a little bit difficult because the mammogram tends to be the one where the radiologist will comment that it doesn't look malignant because
right,
calcium, right. And ultrasound is only really looking whether it is solid, whether it has liquid. You know, it's a little difficult, but I empathize and I'm happy that you have gotten your diagnosis. Mercury is not the sort of diagnosis for a young mother, a mother who is 28 years old, you know, who was breastfeeding her child. You know, it's quite difficult because most of us will say, yeah, it's due to your baby probably now feeding, may have nicked the nipple a little, and probably one of the lymph nodes under there is a little bit inflamed, although they tend to be more under the armpit, you know, which you said you had a lymph node and all of that in the axilla. But, you know, thanks for sharing your story. And it's through this forum, we can get patients to be pushy. We want patients to be pushy. Bother your doctor. You may get frustrated, you know. But say, doctor, this not right, you know. This not feel right, you know. Me not think that one is right, you know. Me hear what you say, but
absolutely
me not too sure.
Absolutely.
Me not too sure. Rather than just say, yeah, the doctor says nothing, man, and the ultrasound says nothing. Because I'm not sure if an ultrasound can say it is not a malignancy without actually looking under the microscope and not seeing those cells growing rapidly. I don't think none of us can sit here and say that that's not breast cancer.
The reason why they did an ultrasound on her is because they said in the young breast where the fat content is different, mammography might not be as diagnostic.
Yes, that's what they said. That's what they said.
I think what you have to consider is the fact that she not only had a lump in her breast, but she had weeping from the nipple. Right? And I think taking those two things into consideration, especially if the lump is closely related to the nipple. In other words, it is very close to the nipple, which speaks to the fact that you may in fact be dealing with a variation of Paget's, where the lump is very close under the nipple, right? And I think those two things together with a high level of suspicion would indicate some form of biopsy.
Just to add my few thoughts.
I can tell by her voice that she's optimistic and she has started her chemotherapy and we wish her the best.
Yeah, she will do well.
She'll do well. Just to add my few thoughts. Thank you very much, Zoom user, for that touching story. And just to say, I mean, the lesson learned is that us, the caregiver and the patient, do not take any lump in your breast for granted, you know? And of course, sometimes some physician and the other caregivers online, we keep learning, as Dr. Riley said, from these seminars, that our patient, they come with a cause and a concern. Let's do our best to ensure that at the end, if it is cancer, we flesh it out. And Zoom user, you did well in that you pursue, you continue, press until you get the best, you get what is happening to you. And that's a type of approach we as a people need to take when it comes to breast cancer. We're not leaving any stone unturned so that at the end of a few decades from now, we can totally eradicate breast cancer if it's possible. I know it's not possible, but that approach is really commendable.
Thank you so much. And thanks again, Zoom user, for sharing. We empathize with you and we will be praying for you. Bishop Webster, could you check on our YouTube channel if there are any questions, please? I'll recognize the hand of Wilma. Please proceed with your question or comment.
Help me, please. Hi, good night, everyone. Listening to the lady before, I too had that concern because I've been doing my routine mammogram checks. And a couple years ago, I did it at the Cancer Society. And they advised me to do ultrasound because the breast was dense and they couldn't see. And they were the first one to tell me to do an ultrasound. I did the ultrasound last year and that was okay. However, the ultrasound that I did this year, sometime September, it shows that there's a cyst. There's something in the left breast. And so they said I should do a follow-up check 6 months' time. But I was thinking, how would they know the difference on an ultrasound? How would they know the difference between a cancer and other problems in the breast? Because the test that I did, it says, I can't read it because I have it on my phone here. It says at the mid 7 o'clock position, there is
as if Miss Wilma's internet is unstable.
No, I'm hearing. She's fine. Go ahead.
Okay, it says at the...
We will get back to her shortly.
No, man, we're hearing you. Is Miss Bishop?
Dr. Emil, we are seeing your name. Are you hearing us clearly?
She's fine. We're hearing her. She's fine.
Go ahead, Miss Wilma.
Miss Wilma, we're not hearing your question.
I'm hearing.
Yes, we're hearing her.
You're hearing her.
You're
Read
hearing
the
her?
results, ma'am.
Yes.
Okay, very well. All right. It says on the left breast at the 7 o'clock position, there is a 0.6 by a 0.3 cm cyst with few internal echoes. Right? And they said there is no mass there. No other on the left breast is seen. Right? But as I said, I was wondering, how would the ultrasound show that it's not a cancer and it's just something else?
All right. With
As
my
Dr. Riley was, go ahead, Vincent.
yes,
So you're
with my
discussing
limited
Dr.
knowledge
Riley.
of radiology, it sounds what you have described is a cyst with some calcium in it, or some the echogenic density which is in there really is probably just from some debris. So cysts tend to be things that you can see nicely in an ultrasound. If it is like, for example, breast cancer, it tends to be a little bit more solid, and they talk about echogenic and rather than echolucent. When they say repeat in 6 months, it's like what in her when she spoke is to see if it has grown in size. Cancer does not remain the same in a 6 months period or a 3 months period. It tends to grow a lot more. So that is what they're really assessing. So in 3 to 6 months, they would reassess it. And then if it has grown, then they would suggest doing a biopsy doing what's called a fine needle biopsy, putting a needle in there, and more than likely, what they'll get is some of the fluid in there. They'll also get the wall of the cyst. Dr. Titus?
Yes, absolutely correct, Vincent. The thing she must look at, one, is the size of it. The size I gave you is less than the size of your little fingernail. It's very small. And the majority, what a cyst is basically is a bag of fluid. It's like a balloon. So it's like a small balloon in your breast. And the majority of cysts are not malignant. They are not cancerous, right? And that is why they are not worried about it. Many, many women have cysts in their breasts. It is one of the consequences, again, of the hormonal changes that you get. A lot of women who will tell you that at or around the time of their menstrual periods, they have mild increase in size and tenderness and swelling of their breasts. It is because their breasts forming little cysts. It's a condition called fibrocystic disease. And this is normal, essentially. It is not a cancer. And if you do an ultrasound of the breast, that's where ultrasounds come into their own. They're able to pick up these cysts. In situations where the cysts are of significant size, that is more than 1 centimeter, and you can feel them, and the ultrasound says they're just full of fluid. Some people opt for treatment where we just put a needle in there, pull out the fluid, and the cyst will disappear. In 50% of them, they will in fact come back. But there are patients, we have had patients who have these cysts in their breasts, and every 6 months, every 9 months, they come and pull out the fluid and they go on about their business and they're fine. But so that's why they suggest a follow-up in 6 months.
Okay, thank you very much, sir.
You're welcome, man.
All right, good evening, everybody. One more time. Question from the YouTube channel for the panelists. What are some of the cost-effective ways of treating breast cancer or any form of cancer as persons from a lower socioeconomic demographic cannot afford treatment?
Go to your public hospital. All the modalities that I've explained are available through your public hospital. Everyone.
And it's free of cost.
And it's free of cost at this time.
Thanks, Ambia, for the YouTube.
That's a simple question to answer.
Thank you, doctors. Dr. Emil, can you hear us clearly?
I am.
Okay, could you be kind enough to introduce yourself and give us your perspective on a person who has been diagnosed and going through treatment, the effect on the individual from a psychological perspective and the effect on the family? Oh, give us some coping tips.
Good night, Madam Bishop, fellow panelists. Good night. Dr. Riley, how are you, sir?
Not too bad at all.
Great. Now, Bishop Webster, good night, sir. As it relates to breast cancer, one of the things that you might find happening with persons who have been diagnosed with breast cancer or having done some operation is that you are going to find the depression raging high.
I said more breast cancer than me, so me can't hear.
And one of the most dominant thing you might see is post-traumatic stress disorder evident, where persons having gone through that might be going through a traumatic period in the aftermath of all of this. And you might find persons start to use unhealthy coping mechanism. Persons might not want to follow up on their doctor's order as to what not to eat and what proportion. And some persons, even though in the minority, might not be sleeping well. Some persons might be undersleeping, some persons might be oversleeping. We refer to it as insomnia for the undersleeping and the hyposomnia for the oversleeping. You might have persons struggling with eating disorder. Some persons might start to overeat. Some persons might start to undereat. And you have persons who might, their self-esteem might be affected and their self-confidence, they might start to struggle with issues like those. And some persons might start to self-blame or to feel guilty about themselves in a negative way. You might even find persons having what we call post-event processing, where persons are looking for things that have happened as it relates to the diagnosis to blame themselves for, which is not necessarily the case, because as the doctors would have said, that cancer might not necessarily have to do anything with the individual. And so a lot of times persons might blame themselves, persons might deny that, oh, I'm having this is not a cancer and all of that. And they take some time before they really catch up to it, denying it, thinking that it might go away. I currently have a client that did an operation to remove one of the breasts last year. And a lot of times you have to be on the phone for extended period of time because she's extremely depressed. Sometimes she's very anxious and the self-esteem is not where it is supposed to be, because she feels less. In a lot of cases, she feels less than other women. But this is not something that any woman should feel less than any other person. Illness is not something that you blame yourself for. You need to, like Zoom user, be positive and engage yourself in the moment, stay in the moment. Don't catastrophize, don't ruminate. So don't think that the future is going to be negative. Be positive, deal with what you have to deal with now. Don't try to deal with tomorrow, today. Deal with everything in the present, in the now. Try to be as relaxed, as calm as possible. Exercise. Make sure that exercise is a part of your daily routine. Dieting is important as well. Pay attention to what the doctor would tell you as it relates to your new diet, or you eat now. Pay attention to that. Talk to people who have survived cancer. Have discussions, get tips from them, and you learn. Have conversations with your doctor, as Zoom user did. Have conversation, be open, be honest, whatever you're feeling, talk to the doctor about it. Don't be afraid to share, because it is in sharing that you gain more information, a greater understanding of what is going on. And that is how you can stay positive and deal with it in the moment. Make sure you get adequate sleep. That is something that is also very, very important. Ensure that you get adequate sleep. And once you pay attention to your medication therapy, as we refer to it as your medication therapy, the time, the amount, all of that, make sure you pay attention to that and match that with conversation with your psychologist. If you need a counselor, ensure that you spend enough time, sit down, talk to the counselor, expose your inner fears. Don't hide your fear, because this is a fear moment, you know. You are going to be afraid. It is something new. You are going to a new stage. So don't be afraid to say that I am fearful. Doctor, I am fearful. I am uncertain. Don't be afraid. And don't minimize yourself because you're afraid. Fear is a normal emotion. And there are days when you are going to feel sad. There are days when you are going to feel hopeless. You are going to feel powerless. It's a normal part of the process. And so that is why you need help, to help you to feel more encouraged, more empowered, so that you can face this. But you can't face it alone. That's why you need your doctor, your counselor, you need your friends, your church group, you need all the support you can get. Back to you, Madam Bishop. Thanks.
Thank you so much, Dr. Philbert Emil. I'm not seeing any questions.
Welcome, Madam.
I'm not seeing any additional questions from the chat. Bishop Webster, are you seeing any further questions from our YouTube users?
No, I'm not seeing any more questions.
All right, we have been online for over an hour. I really appreciate the time spent by our panelists in sharing the information that was shared. I will now invite each panelist in the following order: Dr. Titus, followed by Dr. Riley, then Dr. Wallace, and then Dr. Emil. Just to give us your closing remarks.
Well, just to say that, as what has been echoed through, and especially by the panel and the participants, the treatment of breast cancer is still in evolution. It's still changing. Like any other cancer, it is not a death sentence, not by any means. And the treatments are getting better and better. Early detection, as in any form of cancer, is very, very important. And so we cannot overemphasize the importance of breast self-examination, breast clinical examination, that's when you're examined by a doctor, and the use of especially mammography as a means of evaluating the breast.
Dr. Riley, you're muted.
Yeah, I want to echo some of the sentiments of Dr. Titus. Truly has been a good night. But I want to speak, in my closing remarks about screening. Screening is still the tool for breast cancer, and the guidelines throughout the world has an age for screening. I want to ask Dr. Titus just to remind us about that age group where the persons are for screening.
We're using 40 now.
All right, 40 to what age?
Oh, well, 40 is where you start, and depending on what you find, it varies thereafter. But we start at age 40.
Okay, so Jamaica is using age 40, and that is because of some work which was done by local doctors. A group of local doctors from UWI did the work, and they found that when they follow the guidelines from the rest of the world, a lot of our women were having breast cancer earlier, and some of the persons was later than that was recommended by the international bodies. So we are now screening from age 40. So screening, as he mentioned earlier, is the whole breast self-examination every month at the same time, which you can do is you pick up something, then you bring it to the attention of your doctor, as well as you're going to do in your screening. I'm hoping for the day when Jamaica will get like some of the first world country, that once you reach that age to start screening, that we'll start getting letters from public health. Because, I live part of my life overseas, and you get a letter in the mail, a reminder to tell you that you are now at the age of 50 or 45, and you should start your screening. And you get that letter. You get it every year, every 2 years, to remind you where's the appointment for your mammogram, where you should go, and where you should go, and where you can get back the results. I'm hoping we will get there at some point, because that's the only way we can have early intervention in persons who are diagnosed with breast cancer, such that we can such that we can make an impact on this disease. Dr. Wallace?
Yeah, to echo the sentiments of my senior colleagues and senior panelists, I mean, as we continue to champion the fight against breast cancer and other cancer, to make mention again that breast cancer is not just one person affected, or the entire family. It's a multi-system or multi-community disorder where, each person, a mother, a daughter, a grandmother, a sister, and really, but a brother and a father can be affected. So let's, in our, individual walks of life, if we can encourage somebody to get their breast checked, if we as husband and as male spouse can encourage our partners, or we can examine them, and, just to empathize with those who have been affected, and we continue to be knowledgeable on these platforms so we can spread the news and enhance the fight against breast cancer. Myself breast cancer was always happening around me until I think it was a few months ago. My mother, who have absolutely no risk factor, well, she's a woman, she was above 50, had a mass, and then there it was, she had breast cancer, stage 3, started chemotherapy. So it's something that affects everyone. It may not affect you now, but later on it will. So let us continue to join forces and arm and fight against this cancer. Thank you.
Okay, so I want to join with the other panelists to say that this is not a moment, a suicidal moment or a self-harm moment. This is a life moment. It's a moment where self-care should be at the forefront of your mind, where you now look to take greater care of self and to exercise more patience and understanding, gain more information about your illness, and in doing so, that is how you'll be able to overcome and extend your life. Thank you for having me.
Thank you, gentlemen. Somebody put a question in the chat late, but we're still online. Do you recommend mammogram for someone who has a fibrocystic breast? That's the question.
It doesn't depend. It doesn't depend on the condition. It depends on the person's age. So if they fall within the age group, yes, they should have a mammogram.
And a comment from the chat is that it is a very informative discussion, and Ms. Coombs is saying she's glad she joined. So on behalf of the Bishop Law Foundation and the Hard Place and Wellness Center, Dr. Riley and myself, we say a big thank you to all our panelists for taking the time out. We had a very informative discussion. To all the persons who joined us on this Zoom platform, thanks to all our YouTube users, for persons who participated with their questions and comments. We appreciate you, and we will continue to pray for Zoom user and other persons who may be having this medical challenge at this time, or any medical challenge for that matter. Thanks to Bishop Michael Webster for allowing us and to use his Zoom platform. Have a good night, and watch this space as we will engage you in other discussion on a different type of cancer in the month of November. Have a good night, everyone. Thanks for joining.